Hi, my name is Jillian Bean. This is for Adult Health 2. This is assignment number 3, Professor Norberg. My topic today is on ulcerative colitis. So to start, ulcerative colitis is a type of inflammatory bowel disease and is genetically predisposed, making it an autoimmune disease. Chronic and widespread inflammation of the colon and rectum occur in this disease. The name of ulcerative colitis defines the condition perfectly, which is ulceration of the entire tract of the colon. Per Lewis et al. 2017, ulcerative colitis is caused by an autoimmune disease that includes an immune response in which the body's own defense attacks the intestinal tract, specifically the colon and the rectum. The exact etiology is still unknown. However, specific agents trigger an autoimmune response, such as food, bacteria can do it, and then this leads to inflammation and tissue destruction in the mucosal layer of the colon. So, kind of just want to give you just a really brief look at it. So, this, starting from this point here, the ascending colon, it goes all the way through here, all the way to the rectum there. So it starts or ends, I guess, at the cecum right here. Okay, so per Lewis et al. 2017, inflammatory bowel disease has been linked to genetic mutations and other inflammatory disorders. Ulcerative colitis begins at the rectum and gradually migrates towards the cecum, which causes the breakdown of cells and forms pseudopolyps and ulcers along the bowel tract. Also, I'm going to start referring to it as UC just to make things a little bit quicker. Okay, so the manifestations of UC lead to severe pain, usually acute and in flare-ups, malabsorption of water and electrolytes, dehydration, which leads to or is caused by diarrhea, sometimes bloody diarrhea with mucus in severe cases, fever during flare-ups, dramatic weight loss, usually about 10% of body weight, anemia, fatigue, and anorexia. Diagnostics include or should focus on colon health. So per Hendricks et al. 2016, diagnostics of UC include stool microscopy and stool culture to look for blood in the stool or opportunistic pathogens, including C. diff, E. coli, or Campylobacter and others, or fecal cult blood tests. A blood specimen is also used to check BMP, so basic metabolic panel for electrolyte imbalance. A CBC is used to check for inflammation, infection, or loss of blood. A C-reactive protein test is used to check for inflammation specifically. Imaging studies include double contrast barium enema study, ultrasound, CT, and MRI to closely visualize the area of concern. Colonoscopy is a really good tool to look for ulceration and inflammation of the colon. And then biopsies are used to rule out any other possibilities, such as cancer, for example. It's also wise to check for venous thromboembolus formation because UC patients are at a higher risk for this occurring. So interprofessional care focuses on management of inflammatory bowel disease. Per Lewis et al. 2017, this includes placing the patient on an NPO diet to rest the bowel, decrease inflammation with pharmacological intervention, treat infection if there is one that's present, fix electrolyte imbalance and malnutrition caused by diarrhea and fluid loss, provide pain relief, and help the patient get back to the activities of daily living. This includes hospitalization for moderate to severe cases and tertiary prevention to help stabilize disease so it does not continue to be severe. Surgery can help ulcerative colitis specifically, per Lewis again, a total proctocolectomy, which includes either an IPAA or one with permanent ileostomy, removes the entire colon and rectum, and the patient can either control defecation at the anal sphincter or choose to have an ileostomy bag where continence is not possible, but the pain goes away and suffering. So surgical intervention is typically indicated in the most severe of cases. Okay, so on to medications. So there's a few drugs that we're going to talk about. So drug therapy revolves mainly around inflammatory bowel disease, so it can be used for either Crohn's or ulcerative colitis. However, there are some specifics that can be used for one or the other. So drug therapies for ulcerative colitis include aminosalicylates, antibiotics, corticosteroids, immunosuppressants, biological, and targeted therapy. So per Lewis again, aminosalicylates are an effective medication used for UC and work to lower inflammation by suppressing pro-inflammatory cytokines and inflammatory mediators. Some of these medications include sulfasalazine and mesalamine. It's important to discuss the side effects of these drugs with the child and parents/caregivers. Per Elsevier 2017, these include fatigue, headaches, nausea, abnormal sperm production in males sometimes can occur. And then combination therapy works best other than just doing one route. So, like a suppository and an oral or what have you. Okay, so corticosteroids are the second choice. They are also considered for anti-inflammatory relief. If the aminosalicylates, I'm not going to get that word, don't work for the patient can't tolerate them. Some corticosteroids include prednisone, methylprednisone, and hydrocortisone. They are used short-term if possible because steroids can suppress the immune system and bone marrow. So steroids need to be weaned off of and not stopped abruptly. Very important. Okay, so immunosuppressants can be used after corticosteroids are discontinued to suppress the immune system in hopes of controlling the disease. Some meds include golimumab and infliximab. Sorry. Per Elsevier Inc., 2017, these drugs can lead to bone marrow suppression and inflammation of the pancreas and liver, so CBC must be closely monitored. It can also cause birth defects in pregnant patients. It should not be used for flare-ups. Biological and targeted therapy counteract the immune system and decrease the inflammatory response. However, they are both pricey and risky with side effects. Per Lewis again, TNF agents inhibit cytokine tumor necrosis factor, which is a pro-inflammatory cytokine, and integrin receptor antagonists prevent migration of white blood cells from the bloodstream to inflamed tissue. So TNFs include infliximab and adalimumab, and integrin receptor antagonists include natalizumab and vedolizumab. Per Elsevier again, side effects of these include GI pain and upset, headaches, increased risk of infection, joint pain, hepatitis, TB, malignancies, hepatotoxicity, and hypersensitivity. Lastly, antibiotics are used if infection is suspected or found. This is found by signs, symptoms, and a fecal culture. Okay, on to the nursing process. So with UC, there's several things to consider for planning care. Priorities include pain management, of course, fluid and electrolyte loss from diarrhea, malnutrition, malabsorption, risk for infection, and blood loss. So per Ackley, 2020, a priority nursing diagnosis for the UC patient is imbalanced nutrition, so less than the body requirements or requires, related to anorexia, decreased absorptions of nutrients from gastrointestinal tract as evidenced by diarrhea, weight loss, and malabsorption of water and electrolytes. So short-term goals for the patient include patient progressively gaining weight by properly absorbing nutrients after achieving remission of UC through pharmacological remedies in 1 month's time. The patient will no longer be dehydrated or have electrolyte imbalance after receiving IV fluid therapy before end of hospitalization. And the patient will show improved stool formation by from diarrhea to formed stool after beginning medication therapy that decreases inflammation by the end of hospitalization. So in order to achieve this, some of the nursing interventions for this, some, not all, include administering prescribed medications, so all of the ones that we discussed, to the patient, and watching for side effects and patient response to ensure that the patient is moving towards remission of disease or is getting better. Obviously, some of these medications aren't going to work, so it's important that we monitor and we make sure that the patient is getting what's going to make them better. So the nurse will also administer IV fluid therapy as prescribed to replace electrolytes, fluid, and nutrition to help the patient become stable. The nurse should run a BMP before, during, and after IV therapy to look for any changes. Finally, the nurse will monitor intake and output of stool and urine to look for dehydration as well as stool formation. The nurse will consult with the dietitian to help form a nutrition plan that best meets the needs of this patient's absorption and add additional nutritional supplements as needed. Okay, so lastly, teaching per Elsevier, teaching for the UC patient and the parents / caregivers include proper medication dosing and schedule, side effects to look for and when to seek medical attention, management of the diet and fluid intake, skin and hygiene care around the perianal region and surgical site if surgery was performed, rest for healing purposes, symptoms of flare-ups. Let them know this is a lifelong chronic illness. It may seem better at times, but it does not go away unless surgical intervention is there. That continuous management will be needed for this disease. And then stress ways to reduce stress, such as exercise, music therapy, something that's going to decrease the potential inflammation. So evaluation of this patient includes weight increase, full hydration, adherence to medications with minimal side effects, soft but firm stool, and less pain after starting the anti-inflammatory regimens, as well as returning or being able to return to activities of normal daily living. Thank you so much. I hope you enjoyed the presentation.